Welcome everyone to ArMA's COVID-19 virtual town hall. We'd like to thank you all for taking time out of your evening to join us for another great informative event. A little bit of housekeeping here before we get started. This is a professional environment. We ask that everyone remain respectful towards all participants. The webinar is being recorded and will be published for others to view at a later date on our YouTube channel. You can see and hear the panelists, but we cannot see nor hear you. The best function to contact or talk with us is through the Q&A function on your Zoom screen. The best viewing option is from your computer, and that's also the best way to utilize the Q&A function for those that may have joined in by a phone. Tonight's moderators include myself, Damian Johnson, ArMA's Director of Communications, as well as Megan McCabe, ArMA's Deputy Director of Government Relations. Our guest panelists tonight include Jessica Rigler, Assistant Director of Public Health Preparedness at ADHS, Dr. Rebecca Sunenshine, Medical Director of Disease Control Division at Maricopa County Department of Public Health, as well as ArMA's President, Dr. Ross Goldberg. And at this time, I'm going to turn it over to Dr. Goldberg for a quick update from ArMA.
Thanks, Damian. Thank you, and welcome everyone. Thank you again for joining us. It's what a difference 2 weeks makes from the last time when we met. A lot has happened, obviously. I think this town hall is very timely given what's going on. A shout out to Dr. Murphy for that suggestion. Again, obviously, the last few hours, things have changed drastically for our state, I think hopefully for the better. We have a statement out on that. I'm not going to really dive into it, though one of those topics that was brought up today at the governor's press conference is the whole point of our town hall tonight. So more to come. We will be in contact as always. We thank our guest speakers for taking the time to speak to all of us. And with that, I'll kick it over to Jessica.
Thank you so much, Ross. And thank you everyone for having me back again at one of your town halls. It's really great to be able to speak to you all again today. And we just look forward to sharing a little bit with you and taking your questions. I just wanted to give a very general overview of contact tracing, kind of what it is in the overarching state plan, and then I'll turn it over to Dr. Sunenshine because she's really working to implement this kind of stuff at the local level. So just in general, and I know that most of you know this already, but contact tracing is really a critical tool in the public health toolbox that we have here. It's something that we've used for decades for all kinds of diseases, right? We use contact tracing for sexually transmitted infections, for tuberculosis, for measles, for meningitis. I'm not going to go through the whole list, but essentially it's just public health reaching out to individuals who may have been in contact with someone who's infected with a communicable disease to let them know about their potential risk for disease and give them guidance or recommendations on what they should be doing. And it's something that we do all the time routinely through communicable disease investigation work in public health. As we look to COVID-19, it takes a little bit of a different approach. Typically, we're not doing contact tracing for diseases of this magnitude, right, that are infecting this many people. And so as ADHS has thought through a framework for COVID-19, it's really looking at a scalable framework for contact tracing that supports local health departments in their implementation of these activities. And is flexible to adapt to local health department capacity and what their needs are. So we can provide support as needed at the state level, or if local health departments are good with their staffing, then we can provide technical assistance or other kinds of support. And ADHS has also adopted a technology platform that can be put into use statewide across all of the counties. This is not technology that tracks people down, right? So you might have heard of some of that if you were around someone who has COVID and your phone pinged their phone. This is not the technology that we've got in place right now. The technology we have in place for contact tracing is for follow-up with those contacts. So if we find a consenting contact, we can enroll them in this technology solution and allows them to report their symptoms on a daily basis for public health to follow up. It's not that like Big Brother Bluetooth kind of thing that the news media has talked about. And again, as I mentioned, I know Dr. Sunenshine will provide additional details on what this looks like implemented at the local level. I would also address the press conference today and some things that you may have heard related to that with the National Guard being spun up in order to support contact tracing for the state of Arizona. As the number of cases of COVID-19 have increased here in Arizona, so have the number of contacts. And we know that local health department capacity to contact trace to that surge is just really not there at this moment in time, given the thousands and thousands and thousands of cases that are coming through. And so we're working on training up about 300 National Guardsmen in order to be able to provide that contact tracing support over the next several weeks while we work to surge up additional contractors and staff across the state and at the local level in order to adequately do contact tracing. I also wanted to talk just briefly about some of the dependencies or limitations of contact tracing so that you all have kind of context around that as well. One of those is lab turnaround times. And so we can't even start contact tracing until we identify a case. And we can't identify a case in public health until the laboratory result comes in. And so the timeliness of laboratory reporting is the first linchpin in us being able to do timely contact tracing. Piece number 2 is being able to do a case investigation based on that laboratory turnaround time. Until we talk to a case, we can't find out who they were potentially in contact with, so we can do the contact tracing. So those are 2 critical components for contact tracing. And then, of course, as we see an explosion in cases, it makes contact tracing all the more difficult. When a disease is widespread in the community, contact tracing may not be as effective as contact tracing around a measles case, for example, where you only have a handful of cases. And so we really look at how we can prioritize to make the best use of staff time in order to contact trace those who are at higher risk or most at risk of spreading disease to vulnerable adults. And last, before I turn it over to Dr. Sunenshine, I would just ask from you all, as you're considering how you can integrate with contact tracing in your own practice. One would be if you're interacting with patients and you think that they might have COVID and you're getting ready to put in some kind of communicable disease report to public health, that you do work on getting their contact information and expedite all of public health's job to follow up with them if we've got complete contact information for your patients to start. And then second is to let your patients know that public health will be calling them to follow up if they are testing positive for the disease, so that they're aware they're going to get a phone call from a number maybe they don't know, and they're going to get asked some questions, including who their contacts are, and just to help prepare them for that reach around from public health to be able to do our job in mitigating the spread of disease. I'll turn it over to Dr. Sunenshine now, and we look forward to your questions. Thank you.
Can you hear me now? Great, okay. So thank you for covering all of that context. I just wanted to start first with, can you go to the next slide? Great. I know that everybody knows that the cases have been increasing, but I just wanted to provide a little bit of context with some Maricopa County data to kind of explain why we're doing what we're doing with contact tracing. You've all seen an epi curve like this. This is our Maricopa County epi curve, and you can see that once that stay-at-home order expired on 5/17, about 2 weeks later, things really started sloping up, and those lighter bars that are not yet complete are clearly extending that upward trend. Next slide, please. So this is the hospital capacity data that we get from EM Resource. And it really, it's very complicated. It looks like a bunch of colorful spaghetti, but I really just want you to focus on those top 3 lines. That purple line is the trend of COVID positive inpatients. This isn't just Maricopa County, it's Central Region, which is Maricopa, Pinal, and Gila counties, but the vast majority of the hospitals are in Maricopa County. So the purple line is COVID positive inpatients. That next blue line down there is COVID medical surge beds that are inhabited by a COVID positive inpatient. And that third pink line is inhabited by COVID positive ICU patients. So the context I want to bring to you is that the cases in the hospital are dramatically increasing. And although the numbers of critically ill persons is increasing, it's not increasing at nearly the rate. And we think, we're not sure why, but we think that might be because the people who are more likely to go out in the community and get exposed might be individuals who are at lower risk to require intensive care. And we hope that those high-risk persons are less likely to be exposed, but that remains to be seen. And I did put the percentage of med-surg and ICU beds available in the Central Region, so you can see we do still have some bed availability, but that is something we're watching very closely. Next slide, please. So to get to contact tracing, we did start with very traditional contact tracing. We had that first case on January 25th, and we contact trace the heck out of that poor case. And every single person they ever met, we had we had very strong relationships with all of them because we talked to them multiple times a day. As our cases started to rise, we got to a point where because of that lab turnaround time and the lag from when we got to notify people, we wanted to make sure that they received a call or a contact the minute that we got the lab reported to public health. So now they get a text within 24 hours of receipt of the lab at public health, and that text basically tells them that they're positive, that they need to isolate, that their household members need to quarantine, and then it gives them a website where they can go for more information. And it also provides an online survey so that if they don't wish to get a call from public health, they can provide all of the information online. And we are finding that there's a certain demographic that would much prefer to fill out an online survey and not have a phone conversation with us. Typically our younger, healthier individuals often take that approach. After that survey is done, unless they specifically say, please don't call me, a human calls them afterward to complete the survey if it wasn't already done. And then the contacts are all entered into an online system called Sarah Alert, and that information is transferred to AZ211. This part is still in process. That's our crisis response network. And those individuals are all going to be contacted by Crisis Response Network by July 1st. We've started that process, but it's not fully. Okay, next slide, please. All right. So our goal when the cases started to rise was to interview 400 to 500 per day. And that was just about a month ago we set that goal. At the time, we were seeing about 200 cases per day. And we thought, all right, if we get to the point where we can manage to get to 2 to 3 times the capacity, we'll be golden. So we've hired 82 full-time employees, 60 of which have started, 13 more are pending hire. And AZ211 was hiring 50 people to begin July 1st. Well, we had 1,500 cases in the last 24 hours. So that 400 to 500 goal, although we were able to meet that goal since June 10th, or since last week, we've been able to close between 400 to 500 cases per day. It doesn't come anywhere near the 1,500 a day that we're seeing. So we did actually partner with ASU and U of A, and they're bringing on about 200 more students, which we think will definitely augment up from the 500 a day. But because we don't think that we could hire enough staff to interview all 1,500 per day, we're going into a different process that I'll tell you about now. And I will say that on average, it's 1,000 a day, but that number increases daily. Next slide, please. So our plan moving forward is we're moving to a sort of an upfront automated system where an automated phone call goes as soon as the person's lab result comes in. And again, same information tells them to isolate their household contacts, to quarantine, gives them the website, and tells them that a text will be forthcoming. Then they'll receive an online text with the online survey for everyone with a phone number, and simultaneously everyone without a phone number. ADHS has a great system that's going to help get us contact information, and then we have another one at the county level. We're planning on all high-risk settings. Anybody who checks a box in the online survey indicating that they're in a communal setting like a jail or a nursing home or childcare, school, all of them will get a follow-up phone call by humans. And then for those who don't fill out the survey, all we have, the only information we'll have about them is their age. So we're planning to follow up children and adults older than 65 and follow up with them because we think they'll be less likely to answer a survey. That's where we're going. We're very much excited to hear what the state is going to put together with all these extra resources. And if at any point with or without the state resources, we get to a position where we can actually call everybody right away with a human. We're going to go right back to that plan. This is just to keep this going and make sure that everyone does get the information they need until all of that is stood up at the state. The last thing, and I think Jessica really alluded to it, is that contact tracing alone, when there's this much widespread community spread, really doesn't work by itself. Isolating those who are sick and quarantining, all of those are really key parts of public health and infection control. But we also need a multi-pronged policy approach. And I think we made a huge stride today when we heard the governor announce that he's going to allow locals to potentially put mask rules in place. And we know that mask requirements in public will prevent spread from both symptomatic and asymptomatic positive persons. And that is really going to be a huge part of turning around this curve and flattening it. And then we also know that decreasing gatherings to under 10 people will help prevent the spread. And that's really all I have for you today. We would love anything that ArMA can do to kind of spread the word about all the different things that we're doing, and also how important the policy pieces are. And we're happy to take any questions. Thanks so much for having me today.
Great, thank you both, Jessica and Dr. Sunenshine. We will go ahead and jump right into some questions here from the audience. One question in particular is, are the labs contacting health departments automatically, or do we have to contact you when we get the results from the lab?
Jessica, you want to take that?
Yeah, sure. We do get laboratory reports automatically to the health department, mostly electronically, not all the time.
Yeah, so most labs do report through the state health department, and we at the county do get those. There's a little bit of a delay, but not most of the delay, unfortunately, is with the turnaround time from the labs.
Great, thanks to you both. The next question is, what languages are the text messages and surveys currently available in, and are labs reporting what language the patient speaks?
So labs, unfortunately, lab reports often have very minimal information, and usually the name and the date of birth is present. We hope that contact information is there. For the majority of cases it is, but if there was any room for improvement, we would love that, as Jessica mentioned. The language is not typically reported in the labs. And then the text messages that we send out currently are both, I believe they're both in English and Spanish. And then if we do the automated phone call, we have a brief sentence in Spanish in the beginning that refers to them to our website, which is in Spanish, and then we go on in English because we're having some trouble getting the phone call in Spanish. We're working on that, though.
Great, thank you, Dr. Sunenshine. Another question we have here, how can the family medicine community best assist in the overall contact tracing efforts?
So one of the things, and then I'll let Jessica speak, one of the things that we're working really hard on is to have healthcare providers engage their patients, let them know that they are going to be contacted by the health department. Please let them know, regardless of the result of the test, that they need to be isolating at home, and that if they're positive, that their household members and close contacts will need to quarantine. And then we're also putting together some literature that we hope to be able to distribute and post online, so that you can just hand your patients a card that has all that information on it. And that's something that, we're working on with the hospital CMOs to make available. But if family practitioners would like that, that would be fantastic.
Great.
Yeah, this
Thank
is
you.
Jessica. Oh, sorry, Megan. Didn't mean to interrupt you. I just think it's that communication and helping the patients understand what they can expect from follow-up from public health and giving them some of that guidance on what precautions they can take, while it takes some time for the laboratory result to come back in.
Great feedback, thank you. Next question on the list is, what does it mean to close a case?
Great question. Closing a case means that you've reached them and you've interviewed them, or you've attempted to reach them in multiple different ways, multiple times. We usually try, if we have a phone number, by text, if we have an email, by email, and then also with a letter. And then if we still can't reach them, we have to close it out, and we call them lost to follow-up. I did the numbers, and that's about 7%. So it is very much the minority, but at some point we gotta let go.
Great, thank you. And then just a reminder for all the participants to keep continuing. We're going to try and answer as many questions as we can. Please keep submitting your questions through the Q&A function. This presentation is being recorded along with the slides that were utilized and will be published later on this week on ArMA's YouTube channel. Another question here submitted tonight. Will patients who are contacted by Maricopa County Department of Public Health have already been told that they are COVID positive?
We really hope so. The healthcare provider should be the first one to receive a positive lab result, and they should be contacting the patient. What we found is that's not 100% true, and there are times when we'll reach the patient and we'll be the ones to inform them that they're positive, but the system is supposed to be such that the provider should be doing that. Do you want to add to that, Jessica?
No, I think that covers it.
Okay.
Perfect. And I think this sort of relates to an earlier question, but what % of individuals are you able to contact? An article from another state indicated that they could only get a hold of about 50% of positive patients.
Okay, I would have to do some quick math. Right now, we have contacted 63% of the just over 22,000. Everybody else has had at least one call out to them, and there's only been 7% that we've just had to give up on. I think the big missing number that I don't have for you off the top of my head is the % that we don't have any contact information for. At one time, it was around 15 to 17%, but the state health department is working really hard to get us a system where we get more contact information up front. And so those are not included in our loss to follow-up numbers. So I think that number will go down, will get better.
Thank you, Dr. Sunenshine. What is the turnaround? Another question here for both of you, I believe. What is the turnaround time for the test performed at the public health labs in Arizona?
This is Jessica. Yep. So turnaround time is really variable at laboratories, and it has a lot of dependencies. So it depends, one, on which laboratory is performing the test. It depends on the volume of tests that are coming in to be performed at any given time, and then what the historical volume has been to you. So for example, back mid-May, when the Arizona testing blitz was ramping up, we were seeing very significant turnaround times because labs were being inundated when they weren't previously. And then turnaround times for the next week and a half or so took quite some time. They were very lengthy. Then we saw a shortening of those turnaround times in the interim, and they're unfortunately back up again because we were seeing such a huge influx of cases in Arizona, as well as people who are concerned about being exposed. We do monitor turnaround times on a regular basis. We understand that at this point, they are exceeding 5 days. I think Dr. Sunenshine's graph indicated potentially 10 days for some turnaround times. We've seen them as short as about an average of 2 to 2.5 days. And I'll say from the state health department perspective, we are working with the large commercial laboratories in the state to reach out to identify what some of their gaps or challenges are and what steps that they are looking at doing in order to shorten those turnaround times, because it really is critical to public health mitigation strategy is that we get rapid laboratory results in so we can communicate with those patients and their contacts.
Great, thank you. I know we had several questions about testing turnaround time, so thanks for addressing that. Next question is that for those of us who are Arizona residents but currently quarantined out of state, is it safe for us to fly back to Arizona if A, we wear masks whenever we're out of the house, and B, minimizing time away from our home? In the alternative, how long would you recommend we wait to return?
There's a lot of context, I think, behind this to give a really specific answer on what to do. If an individual is quarantined in another state due to their potential exposure to a COVID case, they should wait out their quarantine and monitor for symptoms before they return back to the state, would be what we recommend. If someone were to return while they were still in quarantine status, we would recommend that they remain at home to finish out their quarantine as much as possible. And if there are reasons that they need to leave the house to seek healthcare, pick up medications, anything like that, then they need to be wearing a mask. Dr. Sunenshine, I don't know if there's anything you want to add to that.
Yes, of course, I would support all of that. And I wasn't sure if the question was, is it safe here? And I would say, regardless of whether you're quarantining or not, we would strongly encourage everyone to wear a mask whenever they're out in public. Just for the reasons that we talked about earlier, because we do have good evidence now, and you know, some of it's newer evidence that cloth face masks really do not only do really well at controlling the source, but there's some evidence that they actually do prevent virus from getting in to some extent.
Both. We'll jump into the next question here. Are there any other public health measures you would suggest to be implemented?
You want to start, Jessica?
Sure, I would love to. So I think, you know, Arizona made a great step forward today with recommendations very strongly allowing local jurisdictions to set mask use policies within their jurisdiction, which is important as those locations identify what the behavior of the virus is in those areas. And because, as Dr. Sunenshine just mentioned, there is significant evidence for mask wearing as being an important mitigation or prevention step for the spread of COVID-19. Also today, some of the guidance that came out was related to requirements that businesses, restaurants, and bars need to put into place in order to slow the spread of disease. And I think that was really important too. As we've seen the state reopen, we know that not all customers or members of the public or businesses are following best practices. So shifting those towards requirements and putting some language in there around enforcement of those requirements, I think will be very helpful in order to better support containment of this virus.
I would echo all of those, plus trying to minimize groups of 10 or more, and then just to reiterate what Dr. Christ has been saying, you know, from day one, it's really important that people who are at high risk really try to avoid going out into public, you know, at all. Because until we get a vaccine, individuals who are at high risk should just try to minimize their exposure as much as possible.
And then here at ArMA, we're working with both departments really on what we can do to help spread that message. We've been fortunate that we've been able to have good conversations throughout this whole pandemic and provide input, as well as be a way to get the message out there. We are now actively doing that as well with our public messaging and aligning with the departments of public health, both county and state. So again, for our members on the town hall, please reach out to us if there's issues and we can help kind of distribute that. But we also have information for you as well and provide that as needed.
Thank you. Next question. Will you have any results made public about the patterns of transmission that contact tracing discovers?
So that's a great question. The state has put case rates by zip code on their website. So I'll let Jessica speak to that. One of the things that we're doing, and now they're affectionately called hotspots, these areas where there is increasing spread noted, We have been working very closely with all long-term care facilities, which does include assisted living and LTACs, very closely since the beginning. We're starting to do more work on looking at each city to see if some cities are seeing higher rates than others and putting together city-specific reports. So we hope to have those available soon, and those will be available to the public. Regarding like actual cases spreading individually, there's so much community spread at this point that it's really hard to tease out individual cases. So it would be more showing maybe heat maps of hotspots rather than sort of a diagram of spread like we did with our very first case.
And this is Jessica. I think on a statewide level, we continue to evaluate which kind of data is the most useful to put out, what's the most reliable data, and what is the most sustainable data that we can maintain, because we're putting out so much data on a daily basis. And so as contact tracing activities get ramped up in Arizona and we identify which kind of data is coming in and how it can best be analyzed, we'll be taking a look at what we can post and how we might do that.
Great, thank you both. The next question I have here are any of the surge beds included in the 11 to 14% bed capacity numbers that were presented?
Those particular numbers do not include surge beds.
Great.
And I would clarify as well, sorry, Megan.
Sorry,
I would clarify
Jessica.
as well, the numbers on the ADHS dashboard that show bed usage also don't include the surge beds.
Thank you. Next question. Since many laboratories are performing tests, has the state or the county health department verified accuracy of results of the different labs that are working on this?
So this is Jessica, early on in the outbreak, when labs were first getting stood up, we did have some requirements where the first 5 or 10 samples that were collected at laboratories that were validated either at our state public health laboratory or CDC, depending on what stage that was in. So we did go through that with several of the laboratories for the diagnostic PCR testing. That is not something that we're currently doing for the serology testing, however.
Do you want to talk about the Abbott ID now? Sorry, or I can do it.
Yeah.
I didn't want to put you on this spot.
No, it's fine. So there are rapid test mechanisms out in Arizona, including the Abbott ID Now machine. As that got rolled out, and I'm sure many of you are aware, it was identified that that machine was pretty good at detecting positive tests. It was not so good at detecting negative test results. And so there were a lot of false negatives coming out of the Abbott machine. The recommendation as it stands now is for individuals who are utilizing the Abbott ID Now machine to make a diagnosis. They can count the positive as a positive, but anyone who's symptomatic who tests negative on that platform needs to have their specimens sent to a more complex laboratory like a SonoraQuest or a LabCorp or the state public health lab for confirmatory testing on that specimen.
Actually, I have a question off that for the two of you. I don't mean to throw you on the spot, but it's off what I heard the governor say earlier regarding this new rapid saliva test. Do we have any more information about that? Because that definitely, my ears perked up when I heard that. I'm all for not having my brain biopsied if I have to get tested. So if we have a saliva test that's rapid and works, do we have any more information about that?
We are really excited about the opportunity that test would provide for the reasons that were discussed at the press conference. For example, you need much less PPE. It's much easier on the patient to spit through a straw than it is to have a swab shoved up your nose. There's a lot of pros to a saliva test. It's still in validation stages right now, and so we're excited to be able to work with ASU as they conduct their validation studies on that test, and we're really hopeful for the outcome. Rutgers University had done some of this work previously to look at validating a saliva test as well, and has shown some promising work there. So we're hopeful that this platform will be great for Arizona. Dr. Sunenshine, I don't know if you have anything you want to add about the ASU test.
Yes, just that we're equally excited about the ASU saliva test, and one of the huge benefits is when you have to just do a really large amount of testing quickly, We're hoping to utilize it potentially in the jails, as well as in long-term care facilities when you want to go through and just do a lot of testing at once. And it's looking like it is just as sensitive as the nasopharyngeal or oropharyngeal swab. So we're excited.
Great. I'm going to try and summarize another multi-part question that we received here. Is there any recommendations, first part here, any recommendations for exposure in office if the patient called back after the visit to let them know that a test became positive? And then if staff still took the appropriate measures of wearing the surgical masks. And then the second part of the question is, are there plans for more N95s distribution to local primary care physicians, such as the Honeywell masks that are being made and other
I'll take the primary care question, and then maybe Jessica can address the Honeywell. When a primary care provider when a patient calls them and lets them know that they have been exposed, what we ask them to do is to assess all of the different providers who were within, face-to-face with that individual within 6 feet without appropriate PPE, which is a mask, eye shield, gown, and gloves. And anybody who was not in full PPE for more than just a minute or two with that patient, we would ask them, because healthcare providers are essential providers, we just ask them to make sure that they wear a mask all the time for the next 14 days and watch for symptoms really, really closely. If it's possible for them to work at home, that's always preferable. And then the other piece of that is if the person was in the waiting room, we ask them to look at the patients that were in the waiting room and put together a line list and notify those patients of possible exposures. And I'll pass the PPE piece to Jessica.
Great, yeah, so for the PPE side, the state continues to work with our partners through the federal government to get shipments of PPE into the state, as well as to purchase PPE that can be distributed throughout the state. That includes N95 masks from that Honeywell contract that we're getting in. We take those in and we distribute them through local public health to provide out to healthcare and first responders in their jurisdiction. So there's a couple of things on that. One is I would encourage folks that need PPE to look at putting in a resource request through their local public health to determine if there are supplies available. I know ArMA was also working on a purchasing contract in order to get bulk purchase pricing in place for ArMA members, but I don't want to speak to what the status of that is. The other thing is we do have the Battelle Critical Care Decontamination System operational in the state of Arizona, and that is a free resource that's available for hospitals, first responders, private practitioners, anyone, and it's specifically for N95 masks, where there's a process where you can send it in for it to be cleaned and decontaminated so you can continue to safely reuse the mask. And we can get that information out again through ArMA. So you all have information about how you could sign up for that process as well.
And then for just the ArMA PPE process, we still are doing that with in joint collaboration with the Maricopa County Medical Society. I know we've done a few orders already. The N95s, I think, are on short supply. I have to double check. I haven't looked at our website in a bit. We also do other things like KN95, gowns, gloves, but the N95s, when they're available, are on there. So yes, that option does still exist as far as I know. And that is, once we have an order filled up from enough people, we send it out and get our shipment, which has been pretty good so far.
And I will add that the supply chain for PPE has opened up quite a bit. Lately, we do have on supply right now about 10 weeks worth of PPE. I think everyone knows that we've been prioritizing it for the long-term care facilities, but the one exception to that are N95s, because long-term care does not tend to need N95s. So that's what we would be most likely to be able to give to primary care providers. So please do submit a resource request. And
just again, for those who didn't see the press conference, it was mentioned today that they're going to, I think it was $10 million could put towards those long-term care facilities for PPE and things like that. So that should hopefully also let that focus on them. That way the other supplies can be for those who need it also.
All very good PPE news. So next question, can you clarify what in public means for mask wearing? Assume it is only an issue when you're not able to physically distance. And second part to the question is, are most other counties in the state performing contact tracing in a similar manner to Maricopa?
I'll start in on this one, and then Dr. Sunenshine, please feel free to jump in. So as far as what does in public mean for the purposes of mask wearing, we encourage individuals to wear masks in public, full stop. Taking off the end clause if you can't physically distance, because there are going to be many situations when people are out in public, they think they can physically distance, and in fact they can't. And so the best practice here is to just wear a mask when out in public. And that's really where we're going with some of our talking points and recommendations that we're providing, and in some of the PSAs and things that we're working on as well. Now I lost this. Oh, contact tracing, and that being the same for what's going on in other counties as well. Counties have varying degrees of contact tracing and what's occurring in the counties, and it really depends on what their staffing levels look like, as well as the number of cases that they have in their county, to see what that looks like. Maricopa certainly has a very robust system, just based on the resourcing that the county has, as well as the number of cases and things, and the number of staff, so they're able to put together some broader systems. There are some counties in the state that has requested ADHS support, and so we're actually conducting contact tracing on their behalf, and that's reaching out to call all of the identified contacts of individual cases to provide them the guidance and what they need to do. So it really varies county by county. All counties are doing some level of contact tracing. The state is doing it on behalf of some counties, and after today, we'll help on the state basis to do some additional coordination on that, which includes training up National Guard, so that there is consistency statewide with contact tracing, particularly for those areas that need additional support.
I don't have anything to add. That was perfect.
Great, thank you. I'm going to jump into the next question here. The card to hand out to likely positive patients sounds very helpful. What is the date that we can expect these in the hospitals to hand out?
I would like to be able to get something like that out in the next week or so. I just need to move it to the top of my list, but it is something that we've heard from hospital CEOs that is a way that they can contribute. So we just want to make it succinct, and then we also would like to coordinate with ADHS, because if it is something that's useful to folks, we want to make sure that it's kind of vetted by all the counties so it can be used more broadly. So we'll reach out to the state, and hopefully we can get something like that in the next couple of weeks.
Great, thank you. Next question is, are the demographics of the cases identified after May 17th, so post termination of the stay home, stay healthy order, are the demographics the same after that date as they were before?
Do you want to take that one, Jessica?
I know, why don't you start, Rebecca, because I know you guys have done some analysis on that and kind of the age breakdown of the cases in Maricopa County in the recent weeks.
You know, I don't have the data in front of me. I think in general, they are tending to be younger overall. And I don't really have any good data on comorbidities right now, just because we've got so many in our queue. So I might rely on you to talk about that.
Okay, so I didn't mean to put you on the spot yet. So I
That's
think
okay.
in general on the age component, we certainly have, prior to the stay-at-home order being lifted, we did see a large proportion of our cases under the age of 45. And that number has increased statewide since the stay-at-home order was lifted.
Mm-hmm.
But we know that testing is most sought by those who are under the age of 45 as well. And so there's some correlation there with who's seeking a test and who's testing positive. We also, just a rough look at the data, it's showing that the vast majority of cases are community cases. They're not cases in congregate settings. So, you know, I think there is something to be said for community spread occurring, particularly since the lifting of the stay-at-home order, particularly among Arizonans who are under the age of 45.
And I can add that about half of our nursing homes or long-term care facilities that had a case have actually gotten off of what we call sort of universal isolation, where every patient is in lockdown and isolation, because they've made it through 28 days without having a new case. So we've made a lot of progress in our long-term care facilities. A lot of that is helped by all those policies put in place and decreased visitation, et cetera. But we are definitely seeing an increased number of cases, unfortunately, in our jails, as well as amongst our homeless population. So that's driving some of our numbers in Maricopa County as well. And we did not see those before May 17th.
Just a quick question before I jump into the next question. Is there a link for that decontamination program that we might be able to share with the participants tonight?
Yeah, let me dive into my email real quick and see if I can pull it out to put to send you this, to throw up in the chat.
Okay, great. And then I'll just jump into another question here. A patient highly suspected clinically to have COVID-19, but a negative NP swab, possible false negative. Do you recommend retesting? And then if so, when?
Wow. So just so you know, I'm a medical epidemiologist. I can tell you that based on the data, if I had a strong clinical suspicion, depending on what the test was, I would probably repeat the test. That being said, once somebody is highly symptomatic, your sensitivity of the test is going to go up quite a bit because you're much more likely to be shedding virus. So if I really strongly suspected it, yes, I would repeat it. I'd repeat it a few days into elevated symptoms. But beyond that, I think if it was 2 negative tests, I would be looking for another cause.
I would just echo that. We've seen that in our practice, you know. And sometimes, look, sometimes there are false negatives. We've had that with some of our surgical patients where they were pre-op negative, they came back for another reason, and they were post-op positive. And it's happened once or twice. Usually it's been pretty good, but once or twice they sneak through. But yeah, if you're worried about them, I would say act like, you know, they have it, even if the test isn't sure. Kind of isolate them for a few days and retest and see. That's all. You're not going to hurt anything by being a little safe. And we all have those stories, right? That you swore the way, you know, that they had the symptoms, they're going to do it, and then you get a test, it's negative, and you're confused. And that can happen. But again, always rely on your clinical judgment. If there's a concern, obviously follow that.
Thanks to you both. Next question is, in some states, there have been reports that contact tracers have received threatening comments from people who are suspicious of the process. Have there been reports of this happening in Arizona? And if not yet, which hopefully not, what's the best way to address that?
If you want to antagonize the
From
National Guard, go ahead.
No, I'll let Dr. Sunenshine just see if they've had anything like that occur with their contact tracers. It's not happened for COVID for ADHS staff, although certainly that is something that we do encounter for communicable disease investigation in general, especially when we're doing STD outreach and those kinds of things. One of the things we're trying to do, though, is to help normalize this contact tracing and help people understand the role of public health. That does involve some PSA development that we're doing that can go on TV and social media and those kinds of channels in order to have people understand quickly what the basics of contact tracing is, why it's important, and that all their information will be kept confidential. But you can't make everyone happy either. Rebecca, I don't know if there's anything specific you want to share about experience with your staff.
Yeah, you know, I think we make so many calls that there's always going to be a certain percent who is not particularly happy that their lab result was reported to the government. There are varying levels of trust of the government. We have some pretty phenomenal investigators on our team, and they're pretty good at de-escalating any angry people. And we also have a whole team of people that are trained to de-escalate and talk people through why their labs are reported to the government. Not everybody wants to be told to isolate or quarantine. We have pretty good luck with talking people down. I'm not aware of any death threats, although I will definitely say that with this particular issue, everyone has a very strong opinion, and whatever policy decision we go with, there will definitely, like Jessica said, be some frustrated people. So we just try to explain the rationale and go from there.
I would say this is where we also can come in if we warn our patients and tell them beforehand and kind of start at a certain level so they're aware of it. That way they may help for those that get antagonistic about it. You know, we have a role to play as well. And if you give someone a heads up, they're not a surprise. If they don't want to answer, then they know they won't answer. So we can help with that too by just making sure we inform our patients on what's going on.
Great, thank you. One of the questions here tonight is, what if your contact, or when you've contacted them and they decline to be quarantined, are there any steps or measures that are taken into consideration at that point?
Yeah, that's the $1 million question. We do have legal authority for sure to isolate somebody who is known to be infectious and is non-compliant with isolation. And I would love for Jessica to comment on this as well. Quarantine has always been a bit trickier because typically quarantine people have been exposed but are not yet symptomatic. So in that situation, we rely very much on strong recommendations, providing them resources through the crisis response network so that they don't have to leave the house, that they can get food delivered and all of those things. And we do everything we can to create an amicable relationship with that person so that they will voluntarily quarantine. We have not yet tried to use legal authority to quarantine because it does take a lot of time and resources, and we found that our staff resources are best used on getting people to voluntarily comply.
That was a great answer. There are legal authorities related to quarantine as well. We've reviewed them early on in this response to determine and ensure that we had those and knew what they were. However, public health is always working towards achieving compliance and not quarantine. And given the fact that this disease is widespread in our community and is often spread asymptomatic, it's probably not a tool we'd be likely to utilize to go that legal route for quarantine, just because there are so many other people out there who may not have even know they've been exposed, who are out and about in public. But, you know, depending on the situation, the ability is there.
Great, thank you to you both. Next question. Will employer-based testing, either individual or pooled testing strategies, be included in the contact tracing efforts?
I can definitely say from a Maricopa County perspective, we are not recommending employer-based testing. In fact, we are specifically asking that employers not require testing prior to returning from work. There's enough evidence out there. There's a really nice German paper that cultures people daily after a positive PCR test, and there's good evidence to show that even though you're PCR positive, you know, for weeks after your original positive test, around after day 9 or day 10, that virus just is no longer viable. So we are not a huge fan of culturing people who were once positive. And then as far as mass testing people who you don't know to be symptomatic or have been exposed, that PCR test really only provides, you know, just a point in time. And since there's so much community exposure, I don't see a big role for it right now. If there was less community spread, maybe, and certainly maybe a role for serology in the future, but at this point, probably not.
Great, thank you. We're going to finish off with one final question here, just to be mindful of both of your time. And then I'll close out with a little one final slide. Is there random sampling of antibody levels for COVID-19 to determine prevalence in the various areas?
Jessica, do you
There
know
is not.
any?
No, there's not current random sampling right now. The University of Arizona is certainly doing some form of sampling for antibody testing by making their antibody testing available to a whole number of different healthcare providers, first responders. There's 31 sites statewide that people can go in to get their blood drawn for U of A's antibody testing, but it's not a random sample. It's a targeted sample. We are looking at potential options for some kind of sentinel surveillance in the state, but that's just not something that we're implementing currently.
And I'm very excited to say that we're partnering with the State Health Department and CDC and Mayo and ASU to do a what's called a CASPR method, which is a validated representative sample of the entire county, typically used for needs assessments following emergencies. But CDC has used it and piloted it in Georgia in a couple of counties, and we're going to use that methodology to do a sero survey in Maricopa County, which we hope to implement in early August. So we will have a very nice representative prevalence of COVID-19 in Maricopa County, and more to follow.
Great, well, thank you. At this time, we're going to conclude tonight's town hall. We'd like to thank both of you for taking time out of your evening to join us. I'd also like to remind the audience that tonight's town hall was recorded and will be published on our YouTube channel in the following days. If you have further questions or concerns that you'd like to have addressed, please do email us at the communications@azmed.org. Again, that's communications@azmed.org. And one final reminder to everyone that's participating is all of the public resources that ArMA has available on its website, such as telemedicine, COVID-19 resources, an FAQ that we've done work with ADHS on, as well as COVID-19 financial resources. Please continue to check back at the resources as we continue to update it as the world changes on an hourly basis, it feels like. But thank you again for everyone joining us, and we hope you have a great evening.
Thank you for having us.